we talk about the supportive care for pancreas cancer patients, but it's very complicated. I mean, pancreas cancer patients have a lot going on from their disease and how they're feeling, and how do we maximize their performance status, maximize their quality of life to be able to receive treatment, but also to improve survival, which we know when your quality of life is better, you live longer. So Winson, tell us a little bit about how when you see a patient with pancreas cancer, what are some of your secret tricks or drugs that you use to help maximize their quality of life?
Well, I think we have to take a step back and also remind ourselves that even though there's been advances in these therapeutic options, at the end of the day, these are still palliative intent therapies. So I think quality of life and symptom control are paramount in terms of the overall goal of comprehensive cancer care. So at our centers, in addition to kind of using certain drugs, we actually engage palliative care very, very early on. So usually by the first or second visit, we involve them. And there are some patients who are really good ECOG 0, and they don't need the services right away, but just putting them in touch is really, really helpful. So that to me is the most important step of all, actually, to engage the right people from the very outset.
And that's actually based on work that was done out of the Harvard system. Beautiful work. It started with non-small cell lung cancer patients where they found, I just love this paper from the New England Journal, where when you bring a palliative care physician in with a medical oncologist compared to a medical oncologist alone from the beginning, that the survival curves look even better than some of the survival curves that we see with chemo, favoring having that supportive care. You know, I joke, Thomas, that you guys are so tough in Germany, but tell us, what are some of your secrets to helping these patients feel better? Do you have palliative care, and what do you do maybe even outside of palliative care?
We have palliative care involved very early on, and we have a different system because patients are more attached to centers, so we don't have long distances. This is a much more regional care, which makes a lot of sense, and it's an advantage to patients. We have even an outpatient palliative care system where patients are really cared for at home. We do quite a bit of parenteral nutrition. In case patients cannot really provide themselves with enough food, and even the enteral nutrition doesn't work in the support, but we really care very early on. As Winson said, we would do that even after the second visit, and also for psycho-oncology, not only for nutritional purposes, but also for psychological purposes. And this is a team, multidisciplinary team, that's very much involved in taking care of patients, and this really benefits patients. And nutrition, I think, is an issue which is undervalued still, and we should do more about that, definitely.
Well, I'll tell you, I'll show my cards. I'm a huge fan of steroids. You know, especially in the pancreas cancer patients, so you have to be wary that a lot of them will have diabetes. But you know, that's one of my trick drugs I use if I don't have palliative care immediately available, or if I'm seeing them first. You know, it seems to make people eat better, feel better. You know, tell us, Tony, what do you do?
You know, we have palliative care embedded into our practice, but I do agree. I mean, I've turned around a lot of patients with a low-dose steroid. I mean, simple 5 milligram, 10 milligram prednisone, and then put them back on. I think to Manny's point, to Manuel's point, I think the most important piece that a lot of physicians miss, and medical oncologists, they essentially assign the wrong performance status to a patient who's actually well performed but symptomatic. If you can control the symptoms, you get them feeling better, then they're more eligible for more aggressive treatment. And they may explain why the introduction of palliative care early improved survival, because those patients actually were able to get more aggressive treatment. And many times, especially in pancreas cancer, a lot of patients get the disservice of being sent early to hospice, not exposed to adequate treatment because of misidentifying the performance status and not involving palliative care ahead, really early in the game.
Ramesh, do you have any secret clinical pearls to give here?
I think it's important to identify patients where things can be reversed. One is gastric outlet obstruction. I frequently see attributed to chemotherapy or the cancer, but there's actually a mechanical obstruction where stenting can help, or even a gastrojejunostomy in some cases. And also frequently undertreated is pancreatic insufficiency.
Yes.
With pancreatic enzymes, I think probably 95% need pancreatic enzymes.
They do,
But maybe 20% get it.
Or they're
less.
underdosed.
Underdosed.
Or less.
The other
Yeah.
thing that for me that has been very interesting moving from Europe to the US, and at least in Massachusetts and in our system, is the use of medical marijuana.
Yeah.
Many patients are using that and prescribing that, and increases appetite, decreases symptoms, it controls diarrhea. I think it's useful. It's useful, and many patients use it.
I'm just jealous because I live in Tennessee.
Although we live in
you're
Arizona and
Google.
we have it, but Mayo Clinic doesn't. It's not in our pathway.
But I think a lot of patients don't tell you that they're on medical marijuana.
Well, it's
I'm a little
accessible
concerned
otherwise.
about drug-drug interactions.
No, for us it's a very well-established system
Well-established.
where you have everything. It's known.
So are you able to prescribe it in your system?
No,
No,
Tony.
no, no. Well, we can. So we can if we want, but
Okay.
but you need to get a special
Yeah, we don't have
license.
that privilege,
And
but-
actually, the easiest thing is to refer the patient to a medical marijuana dispensary where a nurse and a doctor will prescribe and manage. But you get the dose that they're taking. They're taking. It's all done. So there are no secrets, and it's known. Yeah, and sometimes they use, and I like better than the classic tetrahydrocannabidiol, the CMB, the component that doesn't have the neurological effect, so the patients don't get the neurological or psychiatric or psychological effects, but just a medical, more bowel improvement.
You're raising an important point, Manuel, because I think another issue which is undervalued is pain management.
Yes.
Because
Yes.
patients tend not or underreport pain, and you have to ask thrice to really get an appropriate answer, because there is everything is fine. Say, do you have pain? Well, yes, a bit. And they said, when you do it a scale, well, 7 out of 10, maybe 8, but only during short times of the day. And if they have pain, they don't eat. If they don't eat, they lose weight and they deteriorate in ECOG. So I think really getting to the grips with pain management is an important point. Of course, that's what you say, having the whole system in mind, bowel movement, etc. I think this is very important, and we need to really press on that, because patients tend to underreport.
They get worried that they're going to get addicted to pain medicine,
Exactly.
and I keep trying to convince them that they're not. And
Yeah.
sometimes I do tell them that there have been studies that show when you have good pain control, you have less fatigue.
Yeah.
And usually they say, really? So maybe I'll take my pain medicine now.
Yeah.
But yeah, the whole patient, and making sure you have a comprehensive approach